Great. Okay. So this is where's Prima? This is quite a last-minute replacement, right? Essentially, I was a replacement killer for someone. So, and Prima told me you need four scenarios. So I think it's really the four scenarios you guys get to see in so-called fracture in the special situation, and that's exactly what Prima asked me. Show a cyst, show a fibrous dysplasia, a CP, and OI, right? So there it goes. So 4 cases. All right. So first one, I think this is probably very common. Almost all of you who practice, let's say, anything to do pediatric orthopedics, you will end up having a case like that, right? And so there's something like that, and here it goes, like that. And does everyone agree it is a cyst? Okay. Any other differential? Yeah, a lot of people would say either SBC or even put in the ABC and the fibrous dysplasia, right? So therefore, options here, I think almost all of you agree that it has to be fixed. Yeah, everyone agree. No one will do any other things, right? So therefore, to fix this, I showed you before this morning, and I will use that 130-degree plate. Okay. And the technique here, I think early on this, your show that you actually had to use a proximal joystick to control, and I also had to use a fair bit of force to control because these things really floating around, and yet you don't want to devitalize it too much or devascularize too much. Therefore, it's something that you have to take great care in. Sometimes the only bit of bone you can actually catch is this inferior medial corner here. The rest may be really all filled up with cysts. So you are really praying hard that everything you do, you just catch here. All right? Okay, so that's what you try to do. And having done that, then you get back your verbuch to hopefully your distal fragment will come into play and will agree with you. And of course, confirm your lateral screw, having commented on Sandit's lateral screw. So I make sure my lateral view looks a little bit more decent. And this is part I emphasize a lot this morning. Make sure your plate distally must be bicortical and don't make any mistake, because biggest boo-boo is you fix proximally nicely here and you create a fracture distally. That's not good. Okay, so that was like the end product. And then this is the post-op x-ray. And fortunately on follow-up, that's how it looks like. Okay, that's how it looked like finally. And fortunately, this case did not make too much, did not behave badly, as in, otherwise some of them, when they're still actively growing, the bone cysts will even recur and whack off all your demineralized matrix, whatever autograft put in, it doesn't make any difference to them. Okay? Any comments from the faculty?
So did you put bone grafts or no grafts?
I put DBM in this particular case. Yeah. Yes, of course. Just a SBC. Yeah. I would do more taro and add in my even liquid nitrogen. Try to. Yes, straight away. Yeah. Anyway, usually like that, the moment you open it, you can have a very good idea whether this is only SBC. Yeah. Okay. All right. So next case. So this just to is an appetizer. Next case, as Hitesh showed earlier. Okay. A lot of this is a patient with tibia deformity. Before we corrected a case of OI, then you can see that the length is, there's a gross link length discrepancy, and patient had a FD nail put in previously. And then, unfortunately, because it's fairly short, so we did the try to do a lengthening over nail, but we changed the FD nail away to, guess what nail is this? This is all the FDA off the label use. You know what nail is this? Yeah, humerus nail, yes. I love humerus nail because I use a lot for my lengthening over nail in tibia and all that, yeah. So this will happen, you lengthen, and the beauty is that, remember this case, you can see this, there is a fair bit of deformity in distal femur as well. So while lengthen, we also correct the, you can see that also correct the deformity at the distal, so you do your auto-fix, correcting osteotomy for the distal femur, and lengthen this at the same time. So as we lengthen, the patient getting more and more impatient with the external fixator outside, and finally he is quite a big man, so he say he must have it off, and then we protected him with our brace. So ladies and gentlemen, what happened? Yes, Sandeep? Tara, what happened?
No, I'm just waiting to see the next X-ray which will show fracture below this.
Yes. So everybody knows this is going to happen. We actually protected him, right? And then, of course, lo and behold, excitement came. Ta-da! You know. Yeah. And somehow I couldn't find the X-ray. I don't know who hid the X-ray from me. But anyway, it not only that fracture through the regenerate, and it also fractured nicely, like, you know, truncated the humeral nail right at the regenerate. Okay. So of course I had to have a fair bit of fun removing the proximal fragment, the distal fragment, and all that. Yeah, this is really a nightmare. Okay, so what should we do at this moment, my dear faculty?
Go to the next case. So the path of reconstruction in OI is never easy. There are difficulties, there are problems, and I think what I would have done is, once the lengthening was done, I would have removed the humerus nail and maybe would have put a longer nail.
Correct. I think that probably should, a lot of time, I think we should be more proactive in handling this and not wait for things to occur. Yeah. So I agree with you completely.
Secondly, I've done few lengthening with OI, and of course they form good regenerate. That's not a problem, but they don't tolerate very too much amount of lengthening. Meaning you have to do very short lengthenings because the fixator pins don't hold for a very long time. They become loose, and we don't have hydroxyapatite coated pins here. So, I prefer to do shorter pins, shorter lengthenings where I can remove fixator and, if required, do the lengthening later on. And lastly, when you have juxta-articular deformity, rather than doing an osteotomy in a growing child, you have option of using 8 plates.
Yeah, but so this one a little bit more mature.
Yeah. So here you can't use.
Yeah. But anyway, so fortunately, the nice thing about working in the university hospital and not a children's hospital, so I got a lot of adult colleagues who are more than willing to help me. So they taught me all sorts of things, and there it goes. And so we got this huge nail down, and also very fortunate we managed to go it as distal, so that distal enough. Remember, just at the where my deformity correction as well. So that was very, very fortunate. So that was a slide in the end, and we went down, and finally we managed to also exactly restore his length. So in the end, I spare myself all the blushes. Yeah. So it's not the yeah. Okay. So next case is I think Hitesh also show a lot of. I think Hitesh later will show you all these cases with. CP. So this is a kid with. I think he's a GMSC, probably 3. Yeah, and you could see that he had quite good bone on the other side, but yeah, somehow although he behaves more like a diplegia, but I don't know why on this side the bone looks so good. All right, so came in with pain, and mom reported 2-week history. I think I suspect this probably a little bit older. Whoever agree here, Taro and Hitesh?
Yeah.
Comments, please.
Yeah, so two things which come to my mind. First of all, why this bone is so small. So many of the children with cerebral palsy also have neonatal sepsis, and the child may have had a childhood sepsis. So that probably explains. But this is a problem situation now because you have hip which is not in position, along with severe varus and a fracture. So I don't know whether this is happened over a period of time or was that an acute injury.
Mom reported only 2-week history of pain. So I put a big question on that. Hitesh, any comments?
Yeah, what was the, before fracture, the ambulation? It was about functionally ambulator or whether it's...
I think like 3 kind of thing.
3, okay. There are a couple of problem here. The hip is not in proper place. It's
Correct.
decentralized with the fracture.
Correct.
So we need to counsel the family that it's required the procedure to correct the hip as well as because the varus is good for the hip.
I know.
Yeah,
Yes.
but at the same time, hip is not reduced.
Yeah. So any other opinion from the audience? Anyone else? Binod, any opinion? Anything? Pramod, any opinion? No? Okay. So Pramod, tell me quickly, better no opinion. All right. So I think alike. So I thought I was very clever. So here I am. I say, let me be clever. Let's do a osteotomy at the fracture site. Since the fracture give me an ample opportunity to do this osteotomy. So I went in there, I made the cut, I followed the great principle of medialization and distal fragment, put in my osteotomy plate, and like this, and fix your fracture. And at the same time, you think that the hip was not so nicely reduced, right? And the hip also a bit more slopey. So hey, here you go. So I do a dega on top of it, yank it down, put in my graft, and wow, I thought this sounds quite clever. So you got your osteotomy and you got your graft, and you put in. Comments?
Oh, good, very nice.
Are you sure? What do you think I'm showing this?
Yeah, there are the couple of the issue here. It's not only the bone issue, that's the soft tissue issue also should be tackled. So you have done the iliopsoas anadectomy.
Oh, I've done all that, yeah, I've done all that.
Everything
yeah.
has been done.
Yes.
Here the number one, another problem at this point of time, the hip was dislocated since when we don't know. So it's not only the severe soft tissue contracture would also be there along with the hips. So it tends to redislocate also.
Okay. Any other opinion from the audience? Anyone else?
Yes.
Kali? Sorry, anyone else?
What was the status of articular surface when you opened?
Sorry?
The joint surface, the cartilage.
The joint surface is not as nice as what you should be.
It can become the non-painful to the painful hip.
No, exactly what I think Taro suggested could be a touch of neonatal sepsis previously.
Yes,
yeah. Sorry? Oh, I don't need to do any shortening. So I thought it was a beautiful case because the original fracture gave you the perfect thing for. So I was quite excited. I happily doing this, and In Ho Choi was visiting me, so I showing off. I was doing this, showing him. Says, hey, see how you can just convert things like that.
A lot of osteopenia, the bones, a lot of osteopenia, weak bone.
Yeah.
So I just wanted to ask you.
To cut the story short quickly is that so the fixation is good. The hip never re-dislocated, but you know what happened? The head itself, like you say, is no good. So screw gradually appear too long. So I had to remove the screw. And fortunately, after that, the hip till today, 2-year follow-up, was still in place.
Good.
Yeah. So whatever we had done. So in a sense, he had a fracture, but I corrected hip for him. Yeah. Okay.
Good.
So that's something that we learned from here. Okay. Thank you. Thank you. All right. So come to this quickly. So again, very, very familiar to all of you. You will see this kid, I think the time she was 11, and she had a reasonably trivial injury, was doing physical activities in school, in the lesson, and jumped and then fell and reported pain after that and limp. So diagnosis?
Is this monostotic, meaning it's only
Yeah,
in
so
this?
I think almost everyone will agree with that. Will everyone agree with that? Monostotic fibrous dysplasia? Okay, after this kind of survey. All right?
Yeah.
So I think we all agree with you. All right? And again, because here it is, so what with the plan of action? Where's Sandeep? Sandeep is a bit quiet. Okay, never mind, I will spare him. Permal, any? What will be your plan of action here? Okay. Intramedullary implant, is it? Okay,
So
all right.
what are the clinical presentation? What was the main complaint for the patient?
Pain and a limp.
Pain. And
And
is there any limb line discrepancy?
Well, there was very, very mild limb length discrepancy, but pain and limping is the main symptom that she came to see us. Yeah.
Okay.
Yeah. Correct. So that's exactly. They came in with a trivial injury, but you look for fracture line, and there it was. So again, so I a bit like the CP case. So I thought I took this opportunity. If you have a deformity and now you have a fracture, so I will fix your fracture and correct your deformity at the same time, right? So I was very clever again. And then here, and you can see that this one, can all of you see this? Nice classical fibrous dysplasia stuff, which you'll never see in SPC, nor you ever see in ABC. So it's very nice. So like, being a good doctor, I always tend to call my pathologist and then agree it's a benign thing, okay? Then I proceeded. All right, so done this, and then took out my valgus plate, all right? So must lateralize a bit and do a valgus osteotomy at the same time. Okay, reasonable. And well, now I make sure that all these screws must be truly parallel, otherwise Sandeep will look at it. Okay, look quite straight, and I did stick to my principle of, remember the plate must be perfectly along the line of the shaft. So, guess what happened?
You had a fracture at distal end on the plate.
Oh, no, not so bad, because we did such a perfect job, so.
So there are two things I would suggest. I would have liked these screws to go deeper inside the head, across the physis, because
the screw,
centromedullary fixation.
Yes, excellent, yeah. Good point. Any other point? Any other point? Yeah, so I think.
No, not FD rod, because you need to have control over the neck as well.
I think you need a combination of intramedullary plus neck implant.
And
or
yeah.
miss a nail technique, and you can use that.
No, second generation recon nail,
Yeah.
it perfectly works.
Yeah.
If
only
the
thing
child
that-
is younger, then probably you need combination of that. But in this case, you could have got away with a recon type of nail.
Yeah, but the problem is those nail design. I don't think
That's not an easy surgery by any means. Yeah.
There's no sort of design for you to do your nice valgus osteotomy at the same time. Yeah. So So anyway, of course, as we all expected, things are not good. So virus recur. What should we do?
Can you show the X-ray, James?
Never mind, it's bad. I already told you it's bad. You know? It's a bad situation, yeah. Oh, okay, quickly, time's up, quickly, yeah. Yes, Tara, what should we do?
Yeah. So I prefer to do intramedullary nail,
Okay.
and we've designed a very simple nail which is 8 and 9 mm for fibrous dysplasias. I've done few cases where we get very severe deformity, the Shepherd Cook like deformity. Even those you can plan the osteotomies correct with a nail.
Sure.
You can do valgus
Okay.
with a nail.
Yeah. So how many in the audience would use a nail is also? Wow, okay. And you guys are no problem doing a valgus osteotomy with a nail?
Yeah,
There is a technique. So your entry into the proximal fragment goes from the lateral side, and you.
All right, look like so a lot more clever people here. So, I went back to the good old angle blade plate. Yeah, so we can calculate the angle. That's the almost 30 degree I need to correct. So then that's the degree you need to, and get it up. And again, make sure lateral view must pass Sandeep's test. And so I think almost, I think now almost similar to in terms of a neck shaft angle compared to contralateral side. So I think in the end, the good old cheap angle blade plate works better than my more expensive Synthes
So the conclusion is old is gold, right?
Absolutely. So you still prefer, what's your conclusion now? Next time you are treating a patient like this, would you prefer a blade plate or would you put the Synthes proximal femoral?
No, I think for younger patient, I would prefer our the Synthes variable locking plate. But for this is quite. I think later she actually became quite old, probably about 14 or 15. So the bones are quite huge. I think. Yeah. Oh no, we went all the way down. We did MRI all that. So my plate, quite a long plate, go all the way below. Yes, yeah. Correct. I mean, that's why we are very cautious that we did the MRI to make sure I know the distal extent, and then your angle blade plate, you choose a really long one to cover it.
Sandeep, no alendronate. The monoosteotic fibrous dysplasia, you don't use that. It's only for polyosteotic. It will not change the natural history.
Okay.
It's just the fixation and realignment which works. Absolutely. So if you don't fix in the right alignment, fracture will keep on happening, and that's the etiology of fibrous dysplasia. Absolutely. So it's 5:50. You want to go for the next session?
Okay, thank you.